Hello and welcome to the COMLEX Instant Review. Today's topic is going to be Immune Thrombocytopenic Purpura, ITP. ITP actually refers to a primary immune platelet destruction, and so it's mainly a diagnosis of exclusion. The key clinical manifestations include an insidious onset of mucocutaneous bleeding. That's a key word. It's more commonly seen in females, and the ratio is a 3-to-1. And before you make the diagnosis of ITP, you want to rule out other causes. You look at the CBC. For an isolated decrease in platelets, 10% have ITP plus AIHA, which is Evans syndrome. Also, the peripheral smear will show large platelets. And on basement membrane biopsy, you'll see increased megakaryocytes. And if you perform this in adults greater than 60 years of age, you want to rule out myelodysplasia. Sometimes you want to consider the ANA, also viral serologies for HIV, EBV, and hepatitis, and also H. pylori antibodies. Keep in mind that antiplatelet antibody tests are not that useful. And for treatment, approximately 50 to 75% respond to steroids. So on the board exam, that's a key answer you're going to choose. But less than 20% have sustained remission after the taper of steroids. And 65% have long-term remission with splenectomy. So the platelets for bleeding, generally if they go to a level that's really low, such as less than 20,000, then there's a risk of spontaneous bleeding. And it's less so with ITP. And studies show that there's limited benefits without concurrent IVIG or anti-RHD medications. So how do you treat ITP in adults? Well, initially we mentioned steroids. Prednisone can be started with a taper 1 to 1.5 milligrams per kg per day, PO tapered over weeks, versus dexamethasone 40 milligrams PO times 4 days. And this is useful in acutely situations, and for long term there's often side effects that develop. Keep in mind that patients who have RHD positive, then anti-RHD IgG 75 micrograms can be given. Also, with platelet counts less than 5,000, despite giving patients steroids, IVIG is recommended, and it blocks the FC receptors. Keep in mind that if patients are refractory to the above mentioned treatments, then splenectomy or rituximab, which is an anti-CD20 medication which causes decreased platelet clearance and forms an antibody against the B cell, can be used. Danazol and vincristine are also recommended, or azathioprine and cyclophosphamide. So keep all of these in mind as refractory medications when the initial steroids along with IVIG and anti-RHD fail. The boards will like to understand making the diagnosis based upon exclusion and then figuring out the treatment based upon the severity. If there's bleeding, then aminocaproic acid, which inhibits plasmin activation, is recommended, and methylprednisolone 1 gram IV times 3 days is recommended. Those were basically an overview of the treatment of ITP in adults. I want to talk also about heparin-induced thrombocytopenias. There's two types, type 1 and type 2. Keep in mind that type 1 is a direct effect of heparin, and it affects 1 to 4 days after heparin therapy, and the platelet low point is basically greater than 100,000. There's usually no sequela, and the management is to continue heparin and observe. So on the board exam, if you see 1 to 4 days platelet low points are approximately 100,000 or more, then you can observe and continue the heparin. With type 2, it's basically an antibody-mediated IgG versus the platelet factor 4 heparin complex. Now, this usually occurs after days 4 to 10, but it can also occur in less than 24 hours, and that's the key point here. And for these patients, the platelet low points will be much lower, to 30,000 to 70,000. So remember that. And the sequela results in thrombotic events, and also rare hemorrhagic complications can be seen in some patients. Immediately discontinue the heparin, and you want to try some form of alternative anticoagulation. Let's talk about the pathophysiology of the type 2 thrombocytopenias. Well, we mentioned the antibody binds heparin, PF4 complex, and the immune complex binds to the platelets, resulting in platelet activation and further PF4 release, causing platelet aggregates to be removed from circulation. This leads to thrombocytopenia, and a prothrombotic state results because the procoagulants released by the platelets and tissue factors are lined by the endothelial cells that are damaged by the HIT antibodies, causing a increased prothrombotic state. For clinically, patients will have platelet counts less than 100,000, as we mentioned, a history of venous thrombosis such as TVT and PE, or arterial such as limb ischemia, CV, or an MI. And again, for pathologic causes, a positive HIT antibody using PF4 heparin ELISA may be confirmed by a functional platelet aggregation assay. That was just some of the overviews of the pathophysiology and making the diagnosis. Now let's talk about the treatment of type 2. So you discontinue the heparin, including the flushes and the low molecular weight prophylaxis, and you avoid any platelet transfusions. That's a key point. If there's positive risk of thrombosis, you look at alternative anticoagulations like lepuridine or argatroban. So those two medications. And you overlap with warfarin, and you treat for more than 3 months. So that's your general strategy if there's a risk of thrombosis. You try lepuridine or argatroban, and you overlap with warfarin, which is chromogenic 10A to titrate, and you treat with greater than 3 months time period. If it's negative risk for thrombosis in the patient, then you consider screening for DVT. A non-heparin anticoagulation could be considered at least until the platelet count is normalized. And again, there's no consensus on the duration of subsequent anticoagulation. It's likely 1 month if there's no clot formation. But the 3 months in the positive risk for thrombosis is a high yield point. The use of heparin if patient has a history of HIT. Well, what you do here is if there's disappearance of the PF4 antibody, usually 100 days after the diagnosis, then the risk of recurrence of the HIT is usually low. So that's another marker to understand how you should proceed with anticoagulation therapy for patients with HIT. That was a board review of some of the key topics in immune thrombocytopenic purpura and an overview of the different types of heparin-induced thrombocytopenias, along with the pathophysiology, diagnosis, and the generalized treatment approach for anticoagulation. Please visit COMLEXFlashcards.com for additional board review lectures, and good luck in your board review.